Hello, my name is Jean-Pierre Despres from the Quebec Heart Institute in Canada. And this afternoon I had the honor and privilege of co-chairing a tribute session to Dr. Kenneth Cooper, a historical perspective from the Cooper Clinic with my co-chair, Dr. Russ Arena from Chicago. And obviously the contribution of Dr. Cooper to the field of exercise and cardiovascular health is very well known. And it was a great pleasure to listen to him this afternoon. And we'll introduce the participant of the session as we go along. But Dr. Cooper, first of all, thank you for being involved in this tribute symposium this afternoon. What were the key points that you made in your lecture this afternoon?
We need to change the field of medicine from one of too much care too late, preventing disease. It's a whole lot cheaper and more effective to maintain good health than to restore it once it's lost. I talked about that. I talked the value of lifestyle changing. We talked about medications, new surgeries, new technology. You need to go back to the basics. Majority of these things, the problem with cholesterol now, the statin drugs that's in the air, but we know that lifestyle can control cholesterol majority of ways. I think equally as important, I talked about the lifestyle of Americans, what we have in this country, is the discouraging situation we're seeing in our children. Obesity is unparalleled. Diabetes in young children is something we've never seen before. And it's estimated that these children that are born after the year 2000, that we're looking at 1 out of 3 develop diabetes before they're 50 years of age. So I'm trying to promote and preach the practice of preventive medicine.
You're really responsible for us considering now fitness as a vital sign which would be evaluated in clinical practice and target. Now in the tribute symposium, Dr. Grant Tomkinson from Adelaide also provided an international perspective, Grant. So could you summarize for us the key elements of your talk?
Sure, the main thing to understand is physical fitness is a very important indicator of both present and future health. And you can be fit in different ways. You could be strong like a weightlifter, flexible like a gymnast, or skillful like a tennis player. But not all of these types of fitness relate well to good health. The most important type of fitness for good health is your cardiovascular fitness, which is your ability to perform prolonged and exhaustive exercise. And so for the international perspective that I presented on, I looked at historical changes or changes in the aerobic fitness or cardiovascular endurance of children, youth and adults over the last 50 years using data on over 50 million children, youth and adults from well over 50 countries. And what we're able to show conclusively from these studies is that there has been an international decline in people's ability to perform aerobically, a decline that is equivalent to about a 15% decline since 1975. And this is a substantial decline in aerobic fitness, which also indicates that there has been a substantial decline in the general health of people over time.
And that has been a recurrent theme at the global Congress, that there is this pandemic of poor fitness level worldwide, as you pointed out. Now, in that symposium also, Dr. Cooper, you were accompanied by colleagues from Dallas appropriately. So Dr. Levine, in your talk this afternoon, you made the point that there's a lot more in terms of exercise and fitness providing cardio protection. There's a lot more than simply positive effect on the traditional risk factors, right?
Absolutely. There's a lot more to exercise than just risk factors. In fact, if you just look at the risk factors from a typical score like the Framingham score, less than 50% of people who would have their first heart attack could be captured or predicted by having by that risk score. In other words, this is called the prevention paradox. That is, the vast majority of people who are destined to have an infarct are actually considered low risk. So a strategy of prevention focused exclusively on high-risk individual will miss the majority of people who are going to have a heart attack. I'm a physiologist, a cardiovascular physiologist, and so I work at UT Southwestern Medical Center and the Institute for Exercise and Environmental Medicine at THR, and it's been my privilege to collaborate with Ken and the team at the Cooper Clinic for many years, looking at coronary calcium score, for example, as an additional strategy to improve risk stratification, and noting that people who are high fit have a 75% reduction in their risk of cardiovascular events, even if they have a lot of coronary disease. My own research has focused on the compliance of the circulation, the youthful stretchability, if you will, of the heart and the blood vessels. And working with Ken and his team, we've shown that people with a lifelong pattern of physical activity at the highest levels can prevent the shrinking, atrophy, stiffening of the heart and blood vessels that occurs with a sedentary lifestyle. Moreover, and you probably don't need to be an elite masters athlete to accomplish that. 2 or 3 days a week of casual exercise probably isn't enough, but 4 to 5 days of committed exercise over a lifetime is enough to get most of those benefits and preserve youthful cardiovascular structure and function.
So there are really spectacular effects on the structure function and that are associated with being active and fit. Now, Dr. Laura DeFina, you have the privilege of working with Dr. Cooper at the Cooper Clinic Institute. So a few words about your lecture this afternoon.
Thank you. Yes, I do have the absolute honor and privilege of working with Dr. Cooper and trying to spread the fitness message that he has so clearly put together for us over the years. And what my job was to kind of bring together what all the gentlemen spoke about and really a call to physicians that we have to be part of the change that helps people to begin exercising. We all generally know exercise is good for us, but at this juncture, people aren't doing it, and there's literature that suggests if physicians counsel their patients that in fact they will begin an exercise program. So I really, it's a call to action that we must start thinking about fitness and physical activity in the regular clinical exam consistently and regularly to help our patients develop their own exercise program with our help.
Thank you, Laura. Ross, we're both excited about this global conference and this tribute symposium. Your thoughts about it?
Well, I actually have a question to Dr. Cooper or anyone else on the panel. Dr. Cooper, we talked a little bit about the ability of an exercise test to capture things that resting data can't capture. And in 2005, the American Heart Association published a scientific statement on exercise testing in asymptomatic individuals and showed very good data on the diagnostic and prognostic value of that type of test. And since that time, there has been some thinking by some of us that should we start doing exercise testing in the primary care setting and for asymptomatic, apparently healthy individuals. And I just wanted your thoughts on that, if that is something that, I know there's a lot of research that would need to be done to look at efficacy, but is that something you think we should explore in our healthcare system?
I think President George Bush answered that question. No coronary risk, outstanding level of fitness, and severe underlying coronary disease that may have cost him his life. As I said in my presentation, there's nothing known to man totally protect against coronary disease, whether it's medicine, surgery, or marathon running. I do think that if we can start combining the calcification score on our coronary arteries with levels of fitness, we're going to be giant steps ahead. We're talking about having the arterial age versus the chronological age. So taking a person who is totally asymptomatic and put them on a stress test, great dividends for us. We see roughly 16% of our patients that come to the clinic have an abnormal equivocal stress test. Only 5% knew they had it. Almost on a daily or at least a weekly basis, we have people coming in totally unknowledgeable of any problems at all, and they have no coronary risk, they thought. We find a high calcification score, we find abnormal stress tests, and a high lipid profile, put them on the treadmill, end up in the hospital. And that's happening in asymptomatic people. That's one of the most common first symptom of sudden death. Of coronary disease is sudden death. And so I'm convinced that could be dramatically decreased if we learn how to do proper treadmill stress testing. Now, one reason that the treadmill test has been false positives, false negatives, is the technology that's being used. It's been taught for years that you must stop 85% of predicted max using 220 minus the age. Studies have shown, our studies and other, that you will miss 50% of the abnormals if you stop at 85%. So stress testing done properly is a very critical point of a good preventive medical examination, and George Bush is a classic example of that.
Can I add a little bit to that, Ross? And I think, Ken, it is likely to be a bit controversial to talk about stress testing healthy people if you focus on the EKG component. And I think that's where a lot of us in cardiology get lost. We look at what does the ST segment show, and for me, I think that's perhaps the least important or interesting component of the test. And so for a prediction of future events, some strategy, and you talked about many different ones in your presentation, some strategy to quantify fitness is essential. And whether that includes other approaches to try to assess the presence of ischemia or not, then we start to get into questions about false positives and false negatives and what you do with the information. But I don't think anybody would disagree that a tool to measure fitness would be valuable.
I'll just add a little bit to that, Ben. I completely agree that we need to think about how we detach the aerobic exercise test, which provides a wealth of value, from the terminology stress test. And if it's going to be in the primary care setting, we don't call it a stress test per se, because that's attached to someone with symptoms and focusing in on that ECG, but more of an aerobic exercise assessment, and the ECG being one component of that, in addition to hemodynamics, and as we've all discussed, peak MET level and how much value that provides. But changing the terminology and changing the definitions and the expectation from what you get from the test is important.
Absolutely, Ross. I agree completely. And let me also sort of link back to what Laura said in her presentation, because there is a difference between physical fitness, which is what we're talking about, and physical activity. They are closely related, but they're not the same thing. And at the very least, I think our community is pushing this concept of exercise is medicine, and pushing very hard to include a measure of physical activity as part of the vital signs. As important as the weight, the blood pressure, the temperature, the heart rate is an assessment of physical activity, because if you see that that's too low, there are known interventions that you can do that will change physical activity and therefore hopefully change fitness and all the downstream factors that result in cardiovascular disease prevention. Yeah, so I think that this comes back to the issue that JP raised, and that is risk factors and cardiovascular disease and the effect of fitness are not always exactly the same thing.
And if I may add also, I guess we need to give lifestyle a chance. It's one thing to assess global risk, but then obviously if you want to lower global risk solely on the basis of hitting, the LDL cholesterol or the blood pressure, it's a missed opportunity, especially in the context of when you have identified those low, poorly fit individuals. And again, Dr. Cooper and your team, you have schooled us on the importance of identifying those poorly fit individuals. So I guess on that note, we will conclude this discussion on this, which was really a memorable moment, an exciting symposium for all of us. Thank you very much, Dr. Cooper.